everyone and welcome to today's session. Vikas, Rana, Balakrishna, Aryan, Vasim, Sarla, Vandan, Danish and everybody who is online for the Monday Medicine with Dr. Murali. So today we start the class. Let us start with 2 to 3 areas which you need to remember with some mnemonics and a easy way to understand and easy to forget but easy to way to understand is required. So how to remember is important. So we will have a quick 3 to 4 review mnemonics. So very happy to see Tabish, Rizvi and many more 39 online students. Can you please punch whether the voice is loud and clear, doctor? Everybody? Now, the first mnemonic and the first concept today we are going to discuss is the brainstem syndromes. Brainstem syndromes. Yeah. You are given a clinical case and you are asked, is it the midbrain? Is it the pons? Is it the medulla? Is it midline or is it lateral? Where is the stroke? Is the favorite question of the examiner in NEETPG, AIMS, JIPMA, PGI, DNB, FMGE, any exam that you go. So let us master how to remember. Can you give me the board? How to remember the brainstem strokes, how to localize it. For that, you need to know the rule of 4. The rule of 4. So what is the meaning of rule of 4? There are 4 cranial nerves in each section. How many sections you have, doctor? I am trying to make you easy to remember and reproduce in the exam on brainstem strokes, how to localize the lesion based on the clinical presentation. Okay? Now, doc, you have a midbrain, you have a pons, then you have a medulla. So, there are 4 cranial nerves in each section, that is midbrain, pons and medulla. And cranial nerves that can be divided by, that can divide evenly into 12, they are all midline located. Now tell me, doctor, what are the cranial nerves that you know? Forget about 1, 2. Forget about olfactory and optic nerve. I am talking from the cranial nerve 3. So you have cranial nerve 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now tell me, so what are we discussing is, to start with today, the different brainstem stroke syndromes. How are you going to localize is a very, very important question. So, Sarla, Amrit, Akireddy, everybody, can you please punch whether the voice is loud and clear? Yes. Now, what is the rule of 4 that you need to remember? There are 4 cranial nerves in each section. You have midbrain, pons and medulla. So, the cranial nerves that can be divided into 12, they are all midline. Now tell me, what are the cranial nerves? Cranial nerve 1 and 2, we are not anyway talking about them. In the midbrain, what is there? 3 and 4 is there. So, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Now tell me, the big number that you need to remember is 12. Now, is the number 3 is capable of dividing 12? Yes. That is the reason it is midline. Number 4, can it divide 12? Yes. Hence, it is also midline. Can the 5 can divide 12 evenly? No. That is the reason cranial nerve 5 is located in the brainstem laterally. Then cranial nerve 6. Can 6 divide 12? Yes. That's the reason 6 is midline. Then 7, it cannot. That's the reason it is typically located laterally in the brainstem. Then can 8 divide 12? No. That's the reason 8 is also present laterally. Can the 9 can divide? No. That's the reason 9 is also located laterally. 10 is also present laterally. And 11 is also present laterally in the brainstem. Only the 12th cranial nerve once more is present in the midline. So now tell me, doctor, what are all the cranial nerve nuclei which are located medially in the midline? Cranial nerve 3, cranial nerve 4, cranial nerve 6, cranial nerve 12. These 4 cranial nerve nuclei are located medially, that is in the midline is what you have to remember, and the remaining cranial nerves are all located laterally. Give me the slide. So, if you remember this rule of 4, you are the expert in the brainstem stroke syndromes. Now, once more let us summarize this pictorially. 3 and 4 medially, 6 is medial, 12 is medial, whereas 5, 7, 8, 9, 10, 11, they're all laterally located is what you have to remember. Then what is the next important rule of 4s? There are 4 motor syndromes which are midline. 4 motor syndromes which are midline. What are those 4 motor syndromes which are midline? M is medial longitudinal fasciculus. M is the motor tract of upper motor neuron, that is corticospinal tract. M is the medial lemniscus which is carrying proprioception and vibration. M are the motor nuclei of the cranial nerve. These 4 motor syndromes are typically midline. Whenever there is any ischemia or infarction of the midline of the midbrain, midline of the pons, midline of the medulla, anytime midline is involved, then 4 M's you should remember. What are they? M is medial longitudinal fasciculus get affected. M is corticospinal tract get affected typically in the midline infarctions, because the pyramidal tract will be traveling along the midline of the brainstem. M is the medial lemniscus. You are having cuneate tract and gracile tract. They are called dorsal columns, right? They are bringing your proprioception, vibration, touch, everything, no? They all come up to from the spinal cord, they ascend up and reach the lower medulla. And in the lower medulla, typically they decussate and travel. When they decussate and travel up towards thalamus, they form what is called medial lemniscus, is what you need to remember. So, let us write it down on the whiteboard. Sometimes few concepts, doctor, एक white paper लेना, एक pen लेना, दोस्त के साथ बैठना, उसको explain करना. When you are explaining that guy, the concept becomes strong for you. That is the only secret in medicine. Okay? So now, फटाफट बोलो, in the rule of 4, what are the 4 motor syndromes that you are going to remember? Give me the board. Now, yeah, you're on the board. 1, medial longitudinal fasciculus is midline. We are talking about midline. Then, motor tract. What is motor tract of UMN? Corticospinal tract. Corticospinal tract. This is also midline. If the midline of the medulla, midline of the pons, or the midline of the midbrain, if they are affected, then the corticospinal tract is also affected. Corticospinal tract is also affected. Then medial lemniscus. What is medial lemniscus? Basically, the touch, the position, the vibration, all these sensory receptors send information in the spinal cord to the dorsal horn. From the dorsal horn, typically to the dorsal horn. From the dorsal horn, they will be ascending up as cuneate tract and gracile tract, depending on upper limb or lower limb. And they typically reach the lower medulla. Once they reach the lower medulla, there they go to the opposite side, right? And while they are traveling opposite side from medulla to pons to the midbrain, that is called medial lemniscus. So medial lemniscus is also a midline structure, is what you need to remember. Then you are having the motor nuclei which are midline. Already you know, no? What are they? Third, fourth, tell me, what are they? 6, very good. Then 12. They are the ones which get affected. So what is medial longitudinal fasciculus? Already we discussed. What is medial longitudinal fasciculus? Very simple. Medial longitudinal fasciculus kya hota hai? You have to be sure what is medial longitudinal fasciculus. Very simple. Whenever you are looking towards your right, let us say there is a handsome guy or a beautiful girl in the reading room and you are looking towards your right, what's happening? Your right eye is abducting, your left eye is adducting. So, your adducting eye, typically on the left side, let us say your left eye is adducting and your right eye is abducting. So, on the right side in the pons, you are having the 6th cranial nerve, abducens. That makes your right eye to abduct. Then your left side oculomotor will make your left eye to adduct. So how can the coordination can occur between your adducting left eye and abducting right eye unless the oculomotor on the left, abducens on the right, they both should be connected. And that connecting tract is what? Medial longitudinal fasciculus. It is also a midline structure. So अगर midbrain या pons में midline में कुछ lesion हो गया समझो, infarction happened, that is going to affect the medial longitudinal fasciculus, and whenever you are trying to adduct one eye, same time if you want another eye to abduct, the coordination will be gone. So that is typically called the internuclear ophthalmoplegia is what you have to remember. So 4 M's which are typically midline lesions. Medial longitudinal fasciculus get affected in the midline lesions. Motor tract, upper motor neuron get affected in the midline lesions. Medial lemniscus get affected in the midline lesions. And the motor nuclei, 3rd, 4th, 6th, 12th get affected in the midline lesions is what you have to basically remember. That's right. Akkireddy Madhavi, I'm just waiting. One student at least should ask, sir, a medial lemniscus hai na? This is not motor, no, this is sensory. Yeah, a small exception, right? Medial lemniscus. Yum is a common thing that brought it into the list, but medial lemniscus is actually sensory. Absolutely right. Very good. So you're all awake, vibrant and listening. I'm very happy. Now, what is the rule of, can you give me the, what is the rule of force when it comes to the sensory? Spinothalamic tract is lateral. Any lesion like lateral medullary syndrome of Wellenberg in the medulla, that affects the spinothalamic tract. Spinocerebellar tract, between the spinal cord and cerebellum, spinocerebellar tract, that is also laterally located. That is the reason you get ataxia whenever the lateral medulla is affected. Then the sympathetic chain, S for sympathetic chain. That's the reason in the lateral medullary syndrome you get oddness, because sympathetic chain is passing all the way from hypothalamus descending laterally along the brainstem. Then all sensory cranial nerve nuclei, all the sensory cranial nerve nuclei. Just before we discussed now, other than 3, 4, 6, 12, all the remaining cranial nerve nuclei, sensory component is all located laterally in the brainstem. That is how they are all affected, is the rule of 4, which you have to be 100% sure about. So, yes, yeah. Now, doc, let us take one example so that you can easily understand, right? So that you can be able to easily understand. Examiner typically gives a question like this in exam hall. 67-year-old male patient presents with the 4-hour history of diffuse motor weakness on the left side. Diffuse motor weakness on the left side. He is unable to move his eyes to laterally towards the left side. Which is the best location of the lesion in this given stroke is the examiner's question. So how do you interpret this? Fundamentally, the job of a neurologist is like a carpenter or electrician. He will check all the various points and then come to a conclusion as to where the electrical activity has stopped. Is it the transformer, or is it at the switchboard, or is it the local wire? So like that. So doc, first of all, this is a lesion of the brainstem. It is a lesion of the brainstem. That's what you should be sure. Then it is midline in the brainstem. Why midline? Because there is a weakness on his entire left side. That means corticospinal tract is involved. That means it should be midline where the motor corticospinal tract is involved. Then which side is the weakness? Left side is the weakness. So that is the reason which side must be the stroke. It should be on the right side. So it should be a right-sided stroke. Then he is unable to move his eye laterally towards left. That means abducens got affected. So that is the reason cranial nerve 6 is involved. That means pons is involved. Where is cranial nerve 6 located? It is located in the pons. So it is a midline pontine lesion is what you will be able to conclude in the tomorrow's exam. So easy, right? Brainstem, if you know the rule of 4, you can be able to interpret.